Okay.
Well, again, good morning. This is Dana Parsons, and thank you all so much for joining the weekly member call. I'm pleased to let you know that we have Janine Fink-Boyle back again this week to provide us with some updates about where we are with CMS. So she'll be joining us. And then later in the call, Kim Beasley, the Deputy Director with the Office of Licensure and Certification, will be joining us. She has another call, so she'll be on as soon as she gets off of that call. But thank you, Janine, for joining us. And so over to you.
Great. Thank you, Dana. Thank you, Paula. Good morning, everybody. I know that probably a good amount of you were able to get on to the CMS call that they held last night. If you weren't, we're going to talk about some of the highlights on it and still some of the questions. I have a few answers to the questions that came up last week. I'm still waiting for some defined answers, so I'll go through what we do have. But what I'd like to do is start with an overview of the call last night. And so it was about an hour, and there were a few different speakers. Administrator Verma opened it up and talked about a little overview of the interim final rule, which we discussed last week, and touched on the infection control training, which is available to all nursing homes and other providers. That was stressed more than once, that the training, while it is for frontline caregivers, managers, and supervisors, it can be used for other aging services providers and other providers. She asked for a call to action for nursing homes to follow infection control procedures, looking at testing and training, as although there are still some trends in increased cases throughout the country, we know that there are some areas that have spiked up and some that have actually trended down. The rest of the call focused a little bit more on testing, and with the interim final rule and the testing guidelines, looking at the fact that there have been the HHS initiative to send out the either the BD, the Quidel testing machines and the testing kits, and a little bit of information about that. Knowing that there are over 15,000 nursing homes. Make sure I get the right numbers here, that to date there have been 13,477 instruments that have been sent. So that is to just over 13,000 nursing homes, so 13,343 nursing homes. So if you're one of those, you've obviously received them. They said that equates to about 4.7 million tests. And so knowing that there's still a little bit over 2,000 that have to be sent this week. So if you didn't get one this week, 507 instruments will be sent with about 192,000 tests. So if you're still waiting, you could be in the 500 block this week, but remember that the instruments will be delivered by the end of the month, so September 30th. Again, remember you need a CLIA waiver to run that particular instrument in your organization. And with that, the amount of testing kits that they sent, what they're saying is that the testing kits can be used probably 1 time for residents and 2 times for staff. Again, that's an average depending on your census and and the staff that you're testing. So a lot of the questions that came up during the Q&A part, Admiral Gerard was trying to answer them, the Assistant Secretary for HHS. Questions about the fact that, once all those tests are used, nursing homes have been trying to secure more testing materials, and that it's been very difficult. Right now, we know that all of these tests and the test kits have been taken by HHS so that they can distribute to the over 15,000 nursing homes. One of those that came out on the call actually talked about the fact that when they tried to procure more testing materials, that their particular distributor was very high. And so HHS knows that, and what they're working on is they have a call this week with the BD outlets. I think there's 6 different suppliers or 6 different distributors that that have those materials, and with that, then they're looking to make sure that nursing homes are given priority, and that also looking at the fact that since it becomes a free marketplace, how they can bring some of the costs down. Now, on the flip side of that, between Administrator Verma She had also kind of piped in about the fact that there has been funding. So between the provider relief funding in the two different tranches that have gone through, so about 2.5 billion for testing, and then as you know that there's another 2.5 billion in quality programs, and that that second 2.5 billion with the quality programs, that has come out in the last week to 2 weeks, talking about the performance in nursing homes, that nursing homes will be receiving funding regarding the number of positive cases that you have and the reduction of mortality. There's more to come on that, but using the funding that you've received through the provider relief fund, that is what SEMA Burma has brought forward. And I think that everybody knows that, sometimes that funding is probably actually going to run out. And so we know that we at LeadingAge have been advocating for more funding in the new, the relief packages, and will continue to advocate for more funding. There were some other questions that came up on the call before parts of the other presentation about asymptomatic testing, and what was the Admiral referred to 3 different areas to look about asymptomatic testing, because we know with the regulation, it talks about having a positive case, staff, resident. It talks about having an outbreak. And it's not that asymptomatic people should not be tested, but it's using the August 24th FDA frequently asked questions to be reviewing those FAQs. That CMS actually made a statement on August 28th using the antigen testing on asymptomatic residents and individuals. And then also there was some discussion about the PrEP Act. And about the coverage for the PrEP Act. And I know that we have some links on our website. Corey Callahan has been doing a lot of overviews on the PrEP Act, and I can make sure that we get that to all of you there. I think one of the other parts that was important that came up on the call was that HHS is purchasing 150 million antigen tests, which is on this Abbott tax card, and that's a nasal swab, and they will be distributed next week. With those 150 million antigen tests that they purchased, 750,000 of them are going to go to nursing homes in the red and the yellow zone counties. So remember, red is a 2 times a week testing according to the community positivity chart. And so these cards that are going to come will be used to supplement your PCR or your point of care antigen testing. And what they're looking to do is that this will lessen some of the burden regarding the testing materials and within the testing kits. And then you'll also be able to rotate the type of tests in using these. So that it's going to be in the next few weeks that those will be distributed, and then into November and December. And once the bulk that comes to your nursing home, if you're in that red and yellow, the understanding is that to purchase these cards, it's about $5 to $6. So obviously the cost is a lot less than the kits that are using with the current HHS initiative of those manufacturing devices. So we will look forward to that and how that will work. There were some questions that came up regarding a more rapid way to do the antigen testing, and the understanding from the Admiral that he stated is that you can do daisy chain testing, and with that you can do about 10 in an hour. You can incubate and then read. Questions that came up is that what about employees waiting around to be put forth, and that what was stated is that to test staff is that to test them you can schedule employees, that they don't have to be all on the same day. So think about the routine testing of employees, whether it's a particular department or a particular neighborhood, that you don't have to schedule them not all on the same days. Looking again, when I kind of brought up the financial support and testing, we know that in some areas that might be, if you're in a red zone, that the funding that you get could run out in a small number of weeks. And that we know that there's issues with rural areas about turnaround time. And so what was asked about, how do those particular areas keep going and moving? And so with that, the Admiral did state that they know that there will be some lag time in the next few weeks having to do with the marketplace. But if you're in the red county, to really make sure you receive the card-based testing and start using it in the next week. And hopefully that this will reduce the workload and the testing burden as well as the financial burden. I know that that was, in my opinion, that was not a full answer, but at least the question got out there, and we will continue to follow up. Another part that came up during the Q&A was talking about the staff. So staff that would be a contractor, and I know we had some questions about that last week. And so what the answers that came forward were that if there is a, let's say it's a dietitian or a pharmacist that might come in once a month to do their part of their consulting, is that you still need to follow what your staffing model testing plan would be. But the other part of it is that if that particular individual was tested a day or two before, and this was the example that they given. So let's say the dietitian comes into your organization once a month, and 2 days before they were tested, they can bring those results, and those are the results that you'd be documenting. And so with that, you kind of look at some of the particular consultants that come into your organization that might not be there on a weekly basis, but again, that they should be following what you are doing because of the community positivity rate. But again, if they have been tested within a time frame, they can bring that and you can use that as part of your documentation. So I think that got through most everything that was in the call. The last parts of the call focused on, there's a slide deck, and I know we had pushed out the slide deck earlier in the day. And then it's on, it'll be on the article that will get put in tonight. The slide deck just sort of goes overview in a very basic way, the interim final rule with comment, as well as the infection control training. The parts that they stressed again were two provisions related to testing and reporting, the prioritization, symptomatic and outbreak, and the routine testing. Under the community positivity rates, a question that was asked is that, where does this come from? And so the medical director from the CDC that was on the call actually took this question, knowing that they're the ones that are calculating that. Dr. Redfield, he's the director, MD director for CDC. And what his answer is that for the actual community positivity rate, where is it coming from is that they're taking in that county the total number of tests and the total number of positives, and that's how they're calculating. And so that discussion led into another question about, they know that some states have some newer data, or they're compiling information and data from the particular counties. And that what was stated yesterday on the call was that if the state has newer compiled data than the CDC, and that CDC, what I found out, was supposed to be updated weekly. The day is usually Thursdays, but they potentially could be updating it a little bit earlier than Thursdays. However, again, if the state has newer compiled than the CDC, then you can document that you're testing on this data source. So the document. Now, where does that come from? That you need to work with your Department of Health. And I know that, I think Kim, if I remember her name, is going to be on in a little while. So I think that's something to bring up because that was part of the discussion yesterday. I think that is probably the end of everything that I wanted to hit on today. I was on a document that I was putting together, so I'm assuming there's probably some questions. So I didn't know if there's anything that I missed, Dana or Paula and Melissa, that you wanted me to cover.
So there's a bunch of questions in the chat box this morning, Janine.
Yep, I could do my best.
Okay.
All right, I just opened it up. All right. Okay, so I have contacted our contractors, telling them that they are responsible for obtaining COVID testing for their staff that serve our residents at the frequency in which we indicate to them. Some have pushed back and said that we should be responsible financially for testing their staff and also conduct the test. Are we required to actually test and pay for the testing of our contractors? That's a good question. I would say that you're doing business with that organization, whether they're one person coming in or the other. There's nothing in writing to say who's the responsible party. So I think that that's something that as an organization, you need to work with the powers that be of that particular company that you're working with. I know that that's not a solid answer, but I can say that there's nothing in writing about who's financially responsible. But I do want to just put this out there. is that remember that your organization, your nursing home, will be the one that could potentially be cited for something that you do not comply to. So I think I know that funds are limited. I know that workforce is scarce at times, and labor, but I think that that's something that you need to discuss with, whether it's administration, your executive level, your board, and then to discuss with that organization. The next question is, we thought that the positivity rates would update every 2 weeks, but they have already updated 3 times. Are they going to be updated more often? Need to ensure we are checking. Also, if on 9/8 the rate improved, and if the rates are updated again next week, can we then reduce the testing frequency? Can we count 9/8 as week 1 and 9/14 as week 2? Or do we need to wait 1 more week before we reduce the frequency of testing? Okay, so I think I answered the first question, that I was told that it would be updated. This was through CMS, from Evan Schulman directly. Told Jody and I last week that the positivity rates would be updated once a week. So it looks like that they are, according to this, updating 3 times within 2 weeks. That's at least 1 time more. I'm not sure if they'll be updated more often. It just might be a day. According to, I think it's 14 days as you put in here. In this particular instance, I would think that you would have your 2 weeks, but this is something I would ask your Department of Health. Because what I know from the way the requirement is that it is supposed to be the 2 weeks, and it looks like you would have that, but I would verify with the department. Okay, weekly testing, does that mean within 7 tests versus just within the week Sunday to Saturday? For example, if the day of testing changed for the following week, will it be out of compliance if we choose Thursday versus Monday in the previous week of testing? Hold on, I'm reading that one more time in my head. So the way that I understand, and I will verify on this just to make sure, so I don't want anyone to be out of compliance, is that it would be, if you have a set day, you do that set day each week. So if I'm doing Tuesday, I'm doing Tuesday. And so I'm hoping that makes sense. But I am going to make sure that I'm going to follow up on that. So that is TJ Candia. Okay. I just want to make sure, because I know dates mean everything in order to be in compliance. Card-based testing, please explain further. So I haven't seen it, but my understanding it's an Abbott product, and that particular product is a card. It's a nasal swab, and with that, it will go to the red and yellow designated counties by CMS, and with that particular, it's an Abbott Now COVID-19 AG card. And so it's a little card that you'll be able to do a nasal swab, and I think you just swipe it on there. I have not actually seen it, a picture of it or anything, but again, it's something that is being sent out. It doesn't require a reader. As I said, it's just a swab, and it's put on this particular card. I don't know what I don't know what the card is actually made of. I hope that, I think what's important is that the sensitivity, what was said yesterday by the Admiral, is that it's very sensitive in the first week or the first 7 days of the infection. Okay. Oh, hold on, my screen went up. All right. Any way to bill Medicare for the resident tests? My understanding is that Medicaid and Medicare can be billed. Mike, we have some updates on the billing when it comes to whether, I think surveillance cannot be billed, but there's other parts that can. I will make sure that Dana and Paula get a copy of what we have written out for billing, so I don't say anything incorrectly. If you have CLIA waiver questions, who should we contact? We've had a waiver for 20 plus years, but CMS said it would not allow EOC testing. So with the CLIA waiver, I know that there is a the application to apply for the CLIA waiver. I think there are contacts on there. I'd have to go back and look and see, knowing that you had one for 20 years, but I can check on that. I do not have a direct person on the CLIA side to talk to, different from Survey and CERT where we have people to actually talk to on CMS. Okay. A question here about testing consultants who come in once in a while, yet surveyors are not tested. Can you please explain the rationale for this decision? That's a tough one. I'm going to give you what I've heard. And what I have heard through CMS and through the State Survey Association that we work with on occasion is that surveyors are there to do a task in a specific time frame, and that they are not interacting with residents as a staff member would be. And that is the only rationale I've been given. I don't think that it is a solid one, and I'll leave it at that. For contractors, do we need to maintain a copy of their negative results, or will it suffice to have documentation that we have seen their negative results? I would say that you should that's a good question. I don't know if you should, if it's actual, that when they keep saying documentation, and the x-ray techs will show their negative test results on their smartphones each week. That's a good question of what it is that if someone's seen it and that you're signing off. I will find out what the surveyors are going to be actually asking you for. I know that yesterday Seema Verma said that they were having some in-services with their surveyors and going over the particular of the rule and how they will be surveying. This didn't come up on what the documentation would be. For now, I would say to err on the side of caution and get an actual copy of the negative results. But I do know that you have to have a file on that particular person. So let me just, as I said, I will find out about. That's a good question. Okay, Dana, will the CMS data positivity rate suffice from a survey perspective, or is there an expectation to seek more?
Janine, I was just putting that in because the Office of Licensure and Certification had replied to that. I was just putting that in the chat box for everyone.
Okay, thank you. Okay. For reporting all viral antigen testing other than local health department and reporting positives on NHSM, there seems like there is another required reporting into another data system. Although on a call with BD, they indicated the health department the data. So my understanding is that and I think your health department will talk about how you need to report. There's a couple of different systems, and states are doing different things. I know that there's some central reporting. I know that states can sign on to different, I want to call it exchanges. So that's something that I think that you need to talk to the state health on how you'll be reporting. But yes, but you still need to report. And let's see. I know, Dana, you put in the Virginia Department of Health Nursing Home Reporting Guidance. And so let's see. Test consultant vendors who come into the facility frequently, or does that meet the requirement? If we test consultants vendors who come, remember the requirement would be what is your positivity rate in your county. I hope that answers that. According 11, we test if according to my QAPI director, a new CLIA waiver must be completed for to be utilized. That I think is that to answer the 20-year-old. I understand. So what we were told weeks ago was that if you had a CLIA waiver, it would suffice. I don't know anything different. Is that if you have to apply for another one? I'm only told that if you didn't have a CLIA waiver, then this is to go to apply. Rebecca, I'd be interested to know how that process went. If you had a CLIA waiver, so did you get a different number and so forth? If you had to do it over again, if you could email me offline, I would appreciate that because I would like to bring that up to CMS.
And if you don't have Janine's email address, you can email me. This is Dana, and I'll forward it to Janine.
X-ray techs and transport aides, these change and there's no way to determine how frequently they come to the building. Unless we know they come every week, can we exclude them from testing? I will say that they fall into any employee that has to, or any consultant, excuse me, not an employee, any consultant or any contractor, and they are part of the program, your testing plan and your testing program. So I know it is difficult. I understand what you're saying here about how frequently they come in the building. It's just that then if you, whatever schedule you're on, you'll have to make a plan for them to make sure that they're tested, whether it's a specific day, again, depending on what the county positivity rate. Again, if that's some of the questions I have specifically up to CMS, and I have not heard from Evan this week at all, even though, I mean, I know Monday was a holiday, but I keep pushing on getting more of an outline, because I think that that's the most important part. And I know that did come up yesterday on the call, more direction on consultants, contractors, anyone that's not an employee that has this not frequent schedule. CMS the slide
I have a question.
all last night. Where can I find that? I think that I know I can send it to you, Dana, or Melissa, and just let me know if you don't. I think you have it, but I can send it again.
Somebody's talking with the questions. Hold on one second. Let them go.
I just have 2 questions.
Yep, I will try my best.
Do they have any recommendations for, like, our offices are not on the unit? So like our director of nurses offices is not on the unit that has to be tested. How do we still have to include everyone that are in those offices off the unit because the director of nursing goes down to the unit?
Well, so meaning that for routine testing, so routine testing
Yes.
is your staff. Routine testing is all your staff.
I'm sorry, I didn't hear that.
Routine testing is your staff in the nursing home. So it does,
Right. So if you're a CCRC.
Oh, okay, got it. Yep. So then I think we talked a little bit about this last week, is that if that particular individual actually, I always use the word crossing the threshold, like they're working, they might be sitting in an office at another part of the campus or another part of the building, but they actually physically work and actually interact with staff and residents in the nursing home, then they would need to be tested. And if they're in
Okay.
nursing home.
Okay, and then I'm hearing that the surveyors, when they come in, are not to be tested.
That is my understanding and what we have been told so far, correct.
However, this is Dana. They should still go through your screening process.
Yes, sorry, Dana. I'm sorry. Yes.
No, that's okay.
Yes, that is where they should be screened. So I think, Ryan, please keep pushing on vendor testing. Yes, we will. We are rural and drive our samples nearly an hour to a lab to make our MD, hospice, and all staff show up twice a week at the same time and put a driver on the road for off schedule. Serious burden of staff time. Yep. We can't agree with you more. I agree with you. I know LeadingAge agrees with you. You have not received your point of care testing device. The assumption, as I said, it could be in the lot for 500 this week, but then it would still be till the end of the month. Dana, is that question to me?
Are the surveyors?
What are your thoughts on requiring testing of surveyors, or is it
whenever it's appropriate, I'd like to know your thoughts on it, but I'd also like to know the memberships, if they'd like to put that in the chat box, what their thoughts are on requiring testing of surveyors. As we move forward with our advocacy, it would just be important for us to know everyone's thoughts.
Sure. So I think all of you know that I worked in a nursing home for a long time, and ran nursing homes, and I have very strong feelings regarding visitation and how a nursing home really needs to operate. But you're opening the doors to people that have been in other nursing homes, meaning the surveyors. You're opening your doors to survey teams that have been out in the community. And you look at community spread, and you're looking at the positivity of your community rates. Again, this is Janine speaking, and I think everyone knows that they should be surveyed. They should be tested. Excuse me, surveyors. I believe surveyors should be tested.
And Janine, do you how would that information be communicated to the nursing home that that surveyor has been tested? What would your recommendations be on that?
Well, I think it's something to work with your Department of Health. I will say that, and asking the Department of Health to work with the nursing homes and say, because I'm sure surveyors are being tested, in maybe, what we understand is that, out of the 50 different Department of Health regulation, whatever they're called throughout the country, that there are state agencies, there are health departments that are testing their staff. That the answer to, are you testing surveyors, yes or no? It's either yes or no, but there's other pieces to it. Surveyors, they might have different programs where they're being tested monthly, they're being tested weekly. I don't know every particular state, but I think it's something to work with your health department, and to work with your director in the Department of Health, or however the hierarchy is. I don't know the right titles, but I think it's, to look at, what could potentially happen. We know that in Idaho, there are 2 surveyors that tested positive. And so, looking at what is the best for the nursing home, for the safety and the health and the well-being of the staff and the residents.
Thank you. And I really appreciate all the comments too that the members have put in the chat box. Thank you to everyone.
I see.
I wanted to see if Kim Beasley is on. She is now the acting director of the Office of Licensure and Certification. I'm sorry, I think that was just a recent change, so I apologize for not having the correct title. But are you on, Kim?
I'm here, Dana. Can you hear me?
Yes, thank you so much for joining us. We appreciate it. I didn't want to cut you off, Janine, if you had more to speak about, but I wanted to bring Kim into the discussion.
I don't. Thank you.
Well, thank you so much. I'm not sure how much you've heard, Kim, but if you had anything to offer about survey or testing, or any of the questions in the chat box, that would be appreciated. Thank you.
Sure. I can't see the questions because I'm calling in on the phone, but I have heard. I was on for most of the information that's been covered so far. She covered a lot of the information that I was going to, same information that I was just going to share about some of the new supplemental testing, the Abbott Binax, that announcement we heard yesterday. As far as, I know there was a question from one facility about not having received their testing supplies yet. So far, we're showing 236 facilities in Virginia have been sent testing supplies. Not all of those have received them yet. And then there's an additional shipment going out supposedly this week, which would include the remaining, 50-ish facilities. So that's what we know so far on the BD and the Quidel testing instruments. There was a question about CLIA certificates. So CMS has been researching to make sure that every facility has a CLIA certificate of waiver, and they had identified for each state those facilities that were showing up in the system as not having a certificate. Now, what we found out in researching that a little bit further was that there had been some address changes over the years for facilities. Sometimes on the CLIA application, when it was originally submitted, maybe years ago, the type of facility was not indicated as being a skilled nursing facility. So these are all, search criteria that they were using to find those certificates. And so there were, a couple of reasons why some weren't showing up. I believe we had gotten all of those straightened out, and there were 5 left that CMS was still asking us about, and those 5 happened to be facilities, all of them were facilities that are associated with a hospital. I'm not sure if that's the situation with the person who was asking earlier about having a certificate for 20 years and now saying that they had to get a new one. I have this question into CMS because, as many of your members know, under the CLIA regulations, it has always said that that entities at the same address or on the same campus could all fall under the same CLIA certificate. So in many instances, hospitals would have a CLIA certificate that would include, different departments of the hospital. So I think that may be the situation with these facilities. And it seems as though now CMS is kind of changing that, and they're saying, at least from what I've heard, and again, I'm getting clarification, it seems as though now they're saying that these long-term care facilities associated with the hospitals would need to have their own CLIA certificate, independent of, the hospital. So again, getting further clarification on that. So again, I'm not sure if that was the question, if that was the situation with the person who asked the question earlier about already having a certificate for 20 years.
Excuse me, Kim, someone just wrote in the chat box to indicate that not all has been straightened out and that they have no communication back from the OLC and CMS and are still waiting. So if that person wanted to chime in to clarify that comment while we have you, that would be great.
Yeah, absolutely. We have CLIA staff is here every day, and so I can, provide name and number to reach out directly to that person.
Okay, great. I'll follow up and let you know who that is.
Okay. So surveyor testing. CMS addressed this a couple of weeks ago in a call with the states, and the information that they provided at that time was that they did not have a policy regarding surveyor testing, that they were following CDC guidelines. Our surveyors are participating in facility screening protocols. They're also doing self-screening daily, temperatures, monitoring, for any symptoms. They are in the facilities for a limited amount of time. During these focus infection control surveys, they don't have direct contact with any residents, and they're social distancing, and they also wear full PPE to include head coverings and shoe coverings. They're all wearing N95 masks. They've been fit tested. And then the only other remark that CMS made was the fact that they consider surveying an essential function. So that's where we are with that. So that's my response to that.
Kim, I just received a question by email asking, since nursing homes cannot test surveyors, can they ask the surveyors for proof of testing?
No, we're not testing our surveyors, so there would be no information to share.
Okay, thank you. I wanted to go to an earlier question that came in the chat box. I also emailed those to you, but I'll read it. I have contacted our contractors telling them that they are responsible for obtaining COVID testing for their staff that serve our residents at the frequency in which we indicate to them. Some have pushed back and said that we should be responsible financially for testing their staff and also conduct tests on their staff. Are we required to actually test and pay for the testing of our contractors? I wondered if the OLC just had any comments on that.
I don't yet. I did send up a question to CMS yesterday related to contractor testing. And I have not received a response from that from them back on that particular question yet. That's interesting. So I think the way the guidance or the regulation reads, and I'd have to pull it back out. This is just off the top of my head, but I believe it does say that, let me find it here. I'm trying to scan through some of my notes. Let's see. So let's see. Staff is defined as employees, consultants, contractors, volunteers, caregivers who provide care on behalf of the facility and students. Arrangement based on their frequency. Consider whether or not they have actual contact with the residents. And it just says testing for these individuals may have taken place through another source, but the facility must obtain the documentation to show testing was completed within the time frame that corresponds to the facility's testing frequency. So it doesn't say that the facility is responsible for actually conducting the testing on these individuals. It can be, the testing can be through another source. So I guess it's going to depend on really what they can work out in their contract with these other entities. So I don't know that I have a definite answer for that at this time.
Okay, I would ask, thank you, Kim. I would ask if anyone would like to unmute their lines. It may be *6 if you're on the phone, just to have an open discussion.
Hi, Kim. This is Libby Bush calling from Fairfax County, so up here in Northern Virginia. Can you hear me?
Yes, hi, Libby. I can hear you.
Okay. First and foremost, thanks for joining us. Such an important thing to have open communication, and as we all wrestle with this together. As I read the chat box, and I know my colleagues, and I know us here, and I'm learning Minnesota is requiring their surveyors to be tested, I offer that it would be quite a thing to do for trust and credibility for the same thing to happen in the Commonwealth. So for your consideration, I want to put that out there.
Okay.
Thank you. I appreciate that.
Thank you, Libby. This is a great opportunity for us to have an open dialogue. If you don't feel comfortable asking aloud, you can certainly put it in the chat box.
Hi, Kim. It's Ryan with Mountain View Nursing Home. Can you hear me?
Yes, I can.
Thanks for joining us today. I really appreciate it. I would echo what others have said in, both in person and in the chat box, that the regulation, as I understand it, is my contract pharmacist who comes into the building once a month and has no resident contact whatsoever, simply sits at a desk and looks at charts, has to be tested twice a week currently, simply because she comes into the building even without any resident contact whatsoever. Ditto to my groundskeeper that spends 40 hours a week on a lawnmower. But then to hear that surveyors who do come into the building are not tested, particularly the burden that twice a week testing involves currently. We're a very rural facility, and to get our MD, all our hospice staff, all into the building at one time, twice a week for testing is proving to be incredibly challenging. And so I just appeal to you on that grounds.
Yeah, I certainly understand. The landscaper piece has come up a couple of times in different conversations, and I think we had discussed the fact that if they are outside of the building and are not entering any of the buildings, then they would not need to be tested.
I appreciate that clarification. Could you point that, could I see that anywhere in writing for my documentation? But thanks for the clarification.
I don't know. It's not specifically addressed in the guidance. The only thing it does say, I think I read it earlier, was just to prioritize services that are based on their frequency in the facility and whether or not they have contact with the residents.
Kimberly, there was a comment in the chat box. One has the department announced when the OLC will start regular surveys, and the next comment, I was interpreting the regulation to include staff, vendors, contractors who come in weekly or more, not those who come in less than a week. Is that correct?
Can you you broke up in part of it. Can you repeat that?
Sure. I was interpreting the regulation to include staff, vendors, contractors who come in weekly or more, not those who come less than weekly. Is that correct?
No, I would say that would not be correct. There's nothing that defines a frequency of coming in weekly. So there's not an exclusion, in other words, for anyone that comes less than weekly.
Okay, thank you. And the other question, has the department announced when the OLC will restart the regular survey process?
We haven't made an official announcement. We are following the CMS guidance, which came out, I don't know, a few weeks ago now, about resumption of survey activities. And so initially what they had said was, as far as expanding survey activity, they had approved expanding complaint investigations from just IJ, immediate jeopardy complaint investigations, to include the non-immediate jeopardy high, which are our 10-day complaints. And then they had also expanded to include revisits and special focus facilities, and then recertifications that were greater than 15 months for nursing facilities and ICFs. So currently we have worked our way down through the list, and we started with our 10-day complaints and revisits, and we've been out there conducting quite a few ICF recertification, the fundamental recertification surveys for ICFs. And now we have branched into, with the resumption, with the release of the resumption of surveys, we have branched into our other complaint investigations beyond the 10-day complaints. So we're working our way. So to answer your question, the short answer is yes, we have resumed some normal survey activity. So we're working our way down the list.
Great, thank you. Thank you. Another question. Again, if we tested Tuesday this week, and due to shortage of supplies or any other reason, scheduling, etc., and we change to Thursday next week, will that be considered out of compliance because it has been more than 7 days?
I would agree with the person's response prior to me, who mentioned that I think it's probably important to try to stick to that. If you're going to perform testing a certain day of the week, to try to stick to that if at all possible. If there was, some circumstance that came up with, testing supplies not being available, or having, for whatever reason, certainly you would want to document whatever the reason was. But my recommendation would be to try to, if you can, stick to that particular day rather than extending it.
But for extenuating circumstances, they could document it and show that information to the surveyor?
Certainly, I'm not going to say that that would be okay in all. It would be a case by case basis, but certainly you would want to, whatever the extenuating circumstance, you would certainly want to document that.
Hey, Dana.
Yes.
This is Judy Raymond. I have a question. So when you have employees that are on vacation for a week or 2 weeks and they're out of town, or they're not working, they're required to come in to get tested if they're away?
Yeah, no, that did come up in one of the calls with CMS, and they said that if people were out of the facility, for instance, vacation, that they would not need to, and I'm looking through my notes to see if I can find that. They would not need to come in for testing during that time.
Okay, thank you.
Mm-hmm.
A couple of other comments that have come in. On page 3 of the S&C memo, under the definition of facility staff, it states those individuals who are regularly in the facility, example, weekly, and have contact with residents or staff. That's the first comment. And secondly, again, if we have an issue and the testing is greater than 7 days, we need to be able to justify and document this in order to not be cited. Is that correct?
Yes, yeah. If it's going to exceed 7 days, you would definitely want to have documentation of the situation. And the part about, I think that the previous statement that you made about where it says, for example, weekly, I think that's just providing an example. I certainly don't think that weekly is a definite, a criteria to use, that if they're not there weekly, then they are excluded. I don't think that's the intent.
Janine, has CMS provided any clarification to LeadingAge on that?
Dana, I'm sorry, but all that was all broken up. My internet went off and then on. So if you want to just say it one more time, I'm hoping you can hear me right now.
Yes, I can. The issue about is trying to get some definition around the testing for contractors, for individuals who are not regularly in the facility. On page 3 of the memo, under the definition for facility state staff, those individuals who are regularly in the facility, example, weekly, and have contact with resident or staff. The question is weekly kind of the standard there, or is that the intent, or was that not the intent, meaning that even if they're not there weekly, they're still going to have to be tested?
Right. They have not. I have not had any particular defined guidance on that part. So, but I can ask them if they would be putting something forward or if that is the standard.
Okay, thank you.
No problem.
Another comment, it seems that we've gotten many different responses on the consultants, vendors who come once a month. Can they test prior to their visits, or do they have to test weekly or at the same frequency as all staff? Kim or Janine?
This is one of those areas, I think, where we're waiting, at least I know we're waiting on some additional clarification from CMS.
I would say the only part that I heard yesterday on the call was that a consultant or vendor, they have to follow what the plan is, but if they got tested, or they could show that test result. But that again was during the call last night. There is nothing that has been fully defined. So I agree that there needs to be more of a overview of a definition.
Okay, thank you both. We have 3 minutes left. So I wanted to give the opportunity for anyone to take themselves off. Oh, we have a question. How should the POC point of care analyzers results be included in the NHSN reporting?
What's the question? How should they be included?
Yes, how should the results from antigen testing be included in reporting requirements?
I believe on one of the calls that I was on, I heard them say, not that it's in place yet, but there was reference to CDC working on a more streamlined process for nursing homes through the NHSN, and that there would be enforcement discretion as they're trying to get this new tool out. So I know that's not maybe
right.
a good answer right now, but I have heard mention of that, and then also on the CLIA side, there was mention of a grace period for reporting purposes.
The comment says NHSN says antibody test results are not considered appropriate for diagnosis of active COVID-19 infection, and therefore positive results from antibody tests must be excluded from confirmed COVID-19 counts. Are these instruments that CMS gave us considered antibody, and therefore we would always need to get another test when positive, or if a symptomatic person is negative using this instrument?
No, the testing that CMS is sending out is antigen testing, not antibody.
One last comment, what does enforcement discretion mean?
It means that there would be a grace period. That's how I'm interpreting it. At least that's what I heard on the CLIA side.
Okay, thank you. Okay, well, we have reached noon, and I want to thank Janine and Kim so much for being on today. I know that we'll be continuing this discussion. I am copying all of your questions and sending them to both Janine and Kimberly, and as we get clarifications, we'll be sharing those with you all in the daily, our updates that go out on Tuesdays and Thursdays now. So our next call is scheduled for 11 a.m. on September 16th. So I hope everyone has a great rest of your week, and we'll look forward to speaking with you next week.
Thank you.
Thank you.